Hi everyone, my name is Sarah Conti and I'm a second-year pharmacy student at UConn. I will be giving a brief overview of polymyalgia rheumatica for this year's student health fair. This presentation will cover what the disease is, who is at risk of developing it, how its symptoms can affect everyday activities, diagnostic criteria to determine if someone has the disease, treatment for the disease, and side effects of treatment. So, polymyalgia rheumatica, abbreviated PMR, is a chronic inflammatory rheumatic disease. Rheumatic diseases are a class of disease describing various autoimmune and inflammatory diseases that cause the immune system to attack joints, muscles, bones, and organs. The direct cause of PMR is unknown, but genetics and environment may play a factor in developing it. It is characterized by aching and morning stiffness in the neck, shoulders, hips, and pelvis, lasting at least 30 minutes or more. PMR can also occur with a more serious health condition called giant cell arteritis. Giant cell arteritis, also known as Horton's disease, is a chronic inflammation of the arteries and veins surrounding the aorta or temporal artery. The cause of GCA is also unknown, but is believed to involve the immune system attacking the circulatory system. Temporal arteritis describes inflammation specifically around the temporal artery and is considered a medical emergency since this inflammation can cause sudden blindness if not detected early and treated. Temporal arteritis is more specific, as some patients with GCA will not have an inflamed temporal artery. PMR symptoms are systemic, involving aching and stiffness on both sides of the body that last at least 30 minutes each day and persisting for at least 2 weeks. Sometimes aching and stiffness can appear quickly at various times of the day or night. Besides aching and pain, individuals may experience fatigue, anorexia, or fever. GCR symptoms occur near the head and neck since the inflammation is localized to the aortic circulatory system and temporal area. These symptoms may include headache, jaw pain, fatigue, loss of appetite, scalp tenderness, or a visual disorder. A visual disorder may indicate temporal arteritis, which requires immediate treatment. Although PMR patients can develop GCA, both of these are separate diseases. Roughly 15 to 20% of PMR patients can develop GCA in their lifetime, while 40 to 60% of GCA patients can have PMR symptoms. Individuals can have one of these conditions or both of them, but having one does not necessarily mean they will develop the other. The causes of both diseases are still unknown, but they do share the same risk factors. Typically, PMR developed in adults over 50 years old with the average onset of disease at 73 years of age. Women are at greater risk of developing PMR, as 75% of individuals are female. Those of Scandinavian or Northern European descent are also more at risk, though any race or ethnicity can develop the disease. PMR can be triggered by long periods of time without movement, so it can be more difficult when the individual is waking up in the morning and getting out of bed. However, the aching and stiffness should improve as the day continues with more activity, though these instances of aching and stiffness can reoccur at any time throughout the day, depending on the person. As a result of the pain and stiffness, the individual may see their range of motion diminish, making daily tasks more difficult. Examples include, but are not limited to, brushing their hair, dressing, lifting heavy objects, sitting down or getting up from a chair, or having to move sideways like into a vehicle. Because the symptoms of various autoimmune and inflammatory diseases are so similar or can overlap, a differential diagnosis is recommended to rule out other common diseases like rheumatoid arthritis, osteoarthritis, systemic lupus, erythematosus, fibromyalgia, etc. Blood tests can help determine if the individual has PMR. The erythrocyte sedimentation rate can reveal inflammatory activity in the body. The C-reactive protein test measures how much C-reactive protein is in the blood. This protein is made by the liver and is released into the blood in response to inflammation. Oral corticosteroids are considered first-line treatment for individuals with PMR. The corticosteroids are specified further into glucocorticoids and mineralocorticoids. Prednisone is the medication of choice for PMR, and it is a glucocorticoid. The goal is to use the lowest dose possible to relieve a patient's symptoms. Methotrexate can also be used, but only if there is an issue in using prednisone, such as a major side effects, no change in symptoms, or prolonged therapy. NSAIDs such as ibuprofen and naproxen are not recommended and not effective in treating PMR. TNFs are also not recommended based on studies where these drugs failed to meet acceptable PMR treatment outcomes. A key consequence of any corticosteroid use is immunosuppression, which can lead to other symptoms such as osteoporosis or easing bruising, as the body is much slower to recover from injuries or undergo typical processes. Other common side effects include increased appetite and therefore weight gain, insomnia, and cataracts, though this is a more uncommon side effect unless the individual is taking high doses or prolonged use of prednisone. Individuals may experience some of these symptoms and not others, though this is not a full list of symptoms. Here are the references I used if you want to pause and check them out. And this concludes my overview of polymyalgia rheumatica. Thank you so much for watching, and I hope you found this video informative. If you have any questions, please feel free to fill out the Google form or comment below.